Hi, everybody. This lecture is going to cover the complete health history, and we'll talk a little bit more about this during class in terms of like gaining a focused history as well. So I'm just going to kind of cover through each area with a health history. A health history is really, really important because a lot of this is helps you determine current issues that the patient has, as well as health promotion behaviors that the patient previously had. And it kind of looks at patterns of their health essentially. So it's really important to gather a appropriate history on a patient. Obviously, there's different portions, but typically we start with biographical data, like the patient's, date of birth, their sex, all that stuff. So that's more general stuff, and we'll kind of look at each one of these areas as we move through the lecture. Source of history essentially means who you are obtaining that history from, because it's kind of dependent upon, the patient's status. If they are in a critical state, obviously you're going to have to obtain a portion of your history from a significant other, or a family member, etc. So the other area too that you may come into issues with is like the older adult that has dementia. So one thing that we do look at is that patient a reliable historian, essentially? Can you gather a history from that patient and is it accurate? But I'll talk about a little bit of this as we move through. Reason for seeking care is exactly what it means. It's sometimes what we'll typically call the patient's chief complaint. It's the main reason that they're seeking out care at that point in time. However, if you worked in home care or an area, it may not be necessarily an acute issue. It may be more of a health promotion or a regular physical exam. Present health or history of present illness. This kind of goes along again, once again, with that chief complaint. We call it the HPI. So a history of present illness is often, you'll hear the term HPI. And that's basically what we gather on that one area of, or it might be two or whatever the patient's presenting with. But we essentially focus in on that chief complaint and gather a history just on that area. Past health, exactly what it means. Sometimes depending on the patient, it may be like a generalized past health, that you would inquire about, or those critical areas, like do they have cardiovascular disease? Do they have diabetes? So we try to kind of gather pertinent areas essentially with that patient. Family history is really important as well, as we kind of talked about before too, with, obviously there's some genetic tendencies there, whether it's a certain type of cancer, heart disease, diabetes, hypertension. A lot of that has a very strong family history behind it. Not necessarily always, because, it does happen, but we'll go through that when we talk about the genogram too. Review of systems is exactly what it means. Essentially, with a review of systems, we go through each system and ask pertinent questions to identify areas that they may be having a problem with. And I'll go through that as we move through. Functional assessment, we'll talk about this later in the course too when we talk about the older adult. Obviously, it's important for all patients, but a functional assessment is exactly what it means. How is that patient functioning? And we're talking about you'll hear the term ADLs, which is activities of daily living. So we're looking at specifically function here, not managing a disease state. It's more of like, are they mobile? Do they have the ability to shop? Things like that. And I'll go through that at the end too. But we use the term ADLs a lot. So that's activities of daily living, or we use instrumental activities of daily living, which is IADLs. That's performing more complicated tasks, like that would be like balancing a checkbook or paying bills. So it's still a portion of their function, but it has like a higher cognitive level with it essentially. Going to biographic data, obviously this is just very basic stuff. Their name, their address, their age, birthplace, and it kind of depends on where you work and how much you gather here with this. But usually if it's a new admit to the hospital, they're going to be gathering all of this. Marital status, race, ethnicity, occupation, and a lot of this is important because you have to really think about it too. You think about race or you think about sex. There's certain ethnicities or certain races that have more of a tendency to have like diabetes, for instance, or males are more typical to have hypertension. So really, when you think about it, all of these factors are really important to understand that there's a link there too. So it's not just it is gaining, their data, but it's really, there's other reasons behind it as well. And obviously the patient's age has an impact on it as well, or their occupation. If a patient works in a factory setting, they're more at risk for certain injuries, or they're more at risk for certain disease states as well. Um, so those are just things to kind of think about. Source of history, like I mentioned before, obviously this is who you're obtaining your history from. It's typically the patient. And like even when you're doing a history, like usually we'll put in there, who did you obtain the history from? And you could put patient, or you could put significant other, spouse, or maybe a friend or relative. So obviously it depends on, the situation of the patient. You really have to look at that reliability of a patient and the information that you gather from them. Can they communicate properly with you? Do they have a cognitive decline that could potentially affect, them giving you an appropriate history? Because obviously it's really important to gather, the entire picture here. And if they're not reliable, then, that's when we kind of have to move to other sources essentially. Um, Note any special circumstances as well, because obviously, too, you're going to run into patients that English may be a second language or they may not even know English. So at that point in time, a lot of times hospitals, their healthcare settings will have interpreters available, because this is another important thing, too. Or they may have to have a family member kind of help them through the process of this and making sure that things are explained well to them. So interpreters are definitely used in the hospital setting. In terms of reason for seeking care, like I mentioned, this is basically more of a subjective statement. So once again, remember what subjective is. It's basically the patient's own experience, their own words, and basically their own description, for their visit, essentially. It could be, like I mentioned before, I have a sore throat, or, I have abdominal pain, I have pain in my belly, I have had nausea. So basically, we'll put that like their chief complaint or the reason that they're there, kind of, and you can put it in, in quotation marks as well. If you're ever documenting, like, and it's specifically their words, like you could put patient states and then you put quotation mark, whatever they say. We do that a lot too. So remember a symptom, which is that subjective sensation that person feels, essentially. So you can put it in quotation marks because you really do want to kind of put it in their own words as to how they describe it. And remember, all those signs, remember the objective stuff that we are measuring is anything that you would be able to examine, or this would be their labs. And a lot of times it's separated out, but if we write like an HPI, a lot of times, as a nurse practitioner or physician, they do this a lot, but they'll put the patient's, like a brief statement of the patient's own words, and then we kind of move into those signs as well. Like we could put patient presents with fever of 101.2, potassium levels low. I think you get my drift, but sometimes we'll combine them together. But that would be more of an objective component to it. Once again, like I said, their history of present illness, often you'll hear it called an HPI. And a lot of times, like if you looked at your patient's admit note, if there was a note from like the ER or a service was admitting the patient to their service, like let's say it was a neurology service or cardiology, a lot of times they'll have their own HPI for each of the problems, essentially. This is really important because this is how you gather an appropriate history focused on a problem, essentially. And I'm going to cover this in class so that way I give you some examples. And I have a handout that I made on, I tend to use old CART. That's because that's what I was always taught. That's the way that I remember it. But I'll go through that separately because I think that's a really important area that you have to understand and how to gain a focused history essentially on that problem. So we always look for the location, and these might mean a little bit different things when we look at a problem, and I'll go through that in class with you. But let's just say abdominal pain. So we look at location. Where does the patient have, where do you feel belly pain? You can have them point to it. So obviously we're looking for the location there. So it's factors like that. Or is it your right arm or right shoulder that you have pain in? Character or quality. A lot of these actually, let me step back. A lot of these were actually developed to describe pain, essentially. So they kind of gear towards that, but we use it to describe symptoms, essentially. So character or quality would be like, for instance, with abdominal pain. Is it sharp pain? Is it dull pain? Is it like a dull, boring pain? We're kind of just trying to, focus in on that symptom, essentially, and characterize it. Or let's say a cough. Is it a productive cough? Is it a dry, hacky cough? Things like that. So you're just characterizing it. Quantity or severity. Going back to abdominal pain, how bad is this pain? If you were to rate it on a scale of 1 to 10, 10 being the worst, where would you rate your pain? Quantity, like with coughing, that would be, sometimes too, I'll ask like if, is the coughing worse at night? Are you having a difficult time sleeping from it? So you're just kind of trying to, inquire about those symptoms. Timing, when did it start? Um, did it start 5 days ago? Did it just start today? Setting, it kind of depends on the situation though, but setting, it could be when did it start? What were you doing when it happened? So that one kind of varies. Aggravating or relieving factors is another important thing. Is it worse going back to belly pain? Is it worse when you eat? Was it worse when you don't eat? Relieving factors. Is it worse when you take your, or I'm sorry, is it better when you take your medicine? So you're always going to try to figure out and I always ask, what have you done at home? What have you taken at home? What has helped? What has not helped? What makes it worse? What makes it better? That's what we're looking at for those aggravating and relieving factors. Associated factors. Do you notice anything that brings this on? And that might be like eating, like I already kind of mentioned with aggravating. So sometimes they overlap a little bit, which is okay. It just depends on the problem. Patient's perception. I always ask them, have you ever had this before? Have you ever experienced anything like this before? Have you had problems like this? Because a lot of times, sometimes they don't, but sometimes they actually have had bouts of whatever's going on previously, or what do they think it is essentially? The other mnemonic, this is kind of the same thing. It's a little bit shorter than the old CART one, which I'll cover in class with you guys, PQRSTU. You could pick any one that you want to do, whatever's easier for you. I just use old CART because that's the one that I've always used. But P would be provocative or palliative. So what makes it worse? What makes it better? Quality or quantity, kind of the same thing like when I mentioned with the previous slide. How bad is it essentially, or what kind of pain are you feeling? Is it sharp pain, dull pain, achy pain? R stands for region or radiation, which is another important thing too, like abdominal pain. Like once we move into systems, it'll make more sense. But like, let's say for instance, appendicitis. Sometimes the pain, like with appendicitis, will move. Like it'll start by the periumbilical area and move down to the right lower quadrant. So that's why we want to kind of target what area would they note this pain in essentially. Severity, that could be related to how bad does it feel, 1 to 10. Timing or onset, you always want to figure out when it started. Quantify that. What day did it start? How many days has it been going on? Once again, is like the patient's perception of that problem. What do they think it is? This is just a question. Sometimes I feel like it helps if we go through these, but which of the following is a good example of a well-written chief complaint? Patients complaining of chest pain for about 3 days. That's worse with activity and relieved with rest. Pain is 10 out of 10. Patient complaining of chest pain, rule out MI. Patient states, I don't know what the pain is. It's the worst I've ever felt. So you really want to look at one that kind of summarizes, those areas that we inquire about the best. So first, when you're looking at these questions, throw out 2 of them. Usually there's 2 that you can actually just throw out that are not really great answers. And like if you look at number 2, pain is 10 out of 10. Okay, yes, that might be correct or appropriate, but is that the best way to summarize a chief complaint? Probably not, because we don't even know where the pain's at. Patients complaining of chest pain, rule out MI. This one's incorrect too, because you're really not putting anything else with it. When did it start? What's making it better? You can add as much as you want into that chief complaint as you want, and we never write rule out MI. You may see physicians do this, like rule out MI, but typically we shouldn't be doing that. So that one I would scratch. And then number 4, patient states, I don't know what the pain is. This is the worst I've ever felt. This, again, doesn't characterize what's going on with the patient. So they're asking what's a well-written chief complaint. They're not even stating where the pain is at. So that's not, that you could put in your HPI, but I would not put that as like the direct chief complaint. So the answer obviously is 1, the patient's complained of chest pain for 3 days. That's worse with activity and relieved with rest. That way, kind of can quantify it with how many days it's been going on, what's making it worse, what's making it better. And obviously, you could even add more to that if you wanted, but that's the best answer out of all of them. Past medical history, this is really important. And I think as we move through systems, a lot of it falls into place because we'll go through each abnormal. And, I kind of point that out as to what is really important to gather here. And it depends on the patient's age, obviously, as well. But, we inquire about childhood illnesses. Did they have, any illnesses or surgeries even, too? That's another thing we look at. But anything like detrimental, like for instance, this is a good one, doesn't happen anymore, or shouldn't happen, is like polio. Did the patient have polio? Or, usually if you prompt them, if did you have childhood illnesses, usually they'll bring it up. But that can obviously have detrimental effects as the patient gets older and they have a lot of like neuro issues because of it. Or, things like, do they have meningitis? Sometimes patients forget, so sometimes I actually will ask, were you ever hospitalized? So that kind of falls into place as well. Any previous accidents or injuries? Do they have car accidents? Do they have, in a child, do they have an injury from a bike, falling off a bike, or any injury at work, things like that, because a lot of that stuff's very pertinent. Any serious or chronic illnesses. So things like diabetes, heart disease, like, and usually I'll literally will ask, do you have any problems with your heart? Because you want to make sure too, when we're communicating with patients, that we're not using medical jargon that they're not really understanding. And some patients understand, but some don't. So you just got to keep that in mind. Have they had a history of diabetes? Do they have a history of pancreatitis? And like I said, I usually say, do you have any problems with your heart? Did you have any problems with your belly or anything like that? So you kind of make it a little bit easier on the patient. Any previous hospitalizations, you want to know when they were hospitalized. Like typically, especially the older adult, they may forget years, but try to get them to ballpark it as best they can. Like if they were in the hospital for COPD or, they say 10 years ago, try to estimate, what year they were hospitalized. So usually we put the date, at least the year there, and what they were there for. So that's important too. You want to put their previous hospitalization with the certain medical diagnosis that they were, hospitalized for, and put the year. Same thing with operations. You want to, make sure that you try to put down the year that they had it. If they're in for a problem that kind of ties back to like a current or recent operation, then you can put like the month. But typically, like if they said, oh, I had my appendix out as a kid, I would just put the year. Like if they said, 20 years ago, I would put just kind of put it like 1999, they had their appendix removed. Obstetric history, we'll kind of talk about this a little bit too later down the road. But when you get into OB too, you'll cover this more. But we will typically put like it would be gravida 1, para 2. Like we actually separated out into how many times they were pregnant. How many times they actually delivered, how many they had term, how many preterm. So you'll gather that when you get into OB, but you quantify essentially how many times they've been pregnant, because unfortunately some patients have, miscarriages or, they had a baby that passed away, unfortunately. So we want to, look at not only how many times they've been pregnant, but how many births they had or how many preterm births they had. Because a history of preterm birth puts them typically, if they just went into labor preterm and they don't really have a reason why, they're usually at risk for another preterm labor. So we try to quantify that and put numbers. Immunizations is another important area, especially if you think about right now, like with all the measles outbreaks. If you have a patient that's sick and they come in and, they start having a rash, it's very important to assess whether they've had their immunizations, because obviously then we think about those as a differential for, their diagnosis essentially. So same thing, even like the pneumonia vaccine, like, all those vaccines we should be inquiring about. So you always want to put like, whether they're up to date on their vaccines or inquire about that essentially. Last examination date, that would just be like if you put down their primary care provider, who their primary care provider is, you can add that in there. Like did they have a complete physical or something like that. Allergies is another really, really important thing. And this is something that you have to assess all the time, not just when you're gathering a complete health history, but anytime you go to give a medicine to a patient, you always inquire about a history of allergies. In terms of past medical history, I mean, obviously you do want to inquire about seasonal allergies. That's important too. But it's very, very important to inquire about food allergies nowadays, latex allergies, and obviously medication allergies. You always, always, always inquire about what happens or what happened when they were exposed to that allergen. So if they're allergic to peanuts, what kind of response did they have? Did they just have some hives, or did they have swelling of the mouth? Same thing with meds. If they're allergic to penicillin, what kind of allergy did they have? Did they just have a mild rash, or they're not even quite sure, or they were just told they were allergic, or do they have like an anaphylactic type reaction where they had to be hospitalized? So always ask the allergy, always ask the response, and you record it. Current meds, this is another area. There's, especially the older adult, we really have to be very diligent about this because a lot of times patients don't even know what they're taking, or they don't even know what they're taking it for. So we always, make sure, if you can't, if they don't know, I would have like a family member bring in their bag of pills just to verify it, because sometimes, one gets missed and they don't remember that they're on something. And the same thing too, like when they're being discharged, making sure that they're going home on the right meds is another important thing. Like that they're not taking, let's say a good example is a patient's in for severe hypertension. They're added or changed, like a physician may change their meds for their blood pressure. Well, next thing you know, the patient goes home. I see this all the time. They go home and they're taking double. Like they were supposed to be, stopping the one that they were on and changing over. Well, the next thing you know, they're taking 3 pills that they shouldn't be taking, if that makes sense. But so it's an important thing to think about with discharge too. So you always, record what they're on, the dosage, the amount in milligrams, and how many times a day they take it. So that's important too. In terms of a genogram, obviously, typically, like in the clinical setting, you're not typically drawing out a genogram. It's typically to get you to thinking along these lines, and it's trying to pull together what you should be looking for, what generations you should be looking at, and kind of tying that information together to look at that whole big picture for your patient. And we do have one in the health history, and I'll talk to you guys about that health history assignment later. I don't necessarily make you draw a whole computerized genogram. I just want you to look at it in terms of like who should you be inquiring about with the patient, what's important, or what medical history is important in previous generations that you should be thinking about. So obviously, you've probably seen a genogram at some point in time, but usually they'll have a key, like you can see it at this bottom one, that will indicate, male, female, marriage. Because you actually too, another thing is you think about psychosocial areas. If they had a child that passed away, there's other things that you can pull out of a genogram too. But really, a genogram or a family tree is truly to assess, basically the risk for disease, essentially. So we're looking at those diseases that have a genetic tendency there. Big ones, like we probably already know, would be like heart disease. Like there's some good examples on here. Heart attack. That's very important to know that, a paternal or maternal grandfather, grandmother, etc., whoever it may be, had a heart attack. And asking the age is important too, because if the patient, let's say their grandfather had a heart attack at the age of 55, that's a red flag too. That's a very, very young age to have, an MI. So that just puts people more at risk, essentially. Other things like cancer, like there's another example. Breast cancer is a big one. Colon cancer is a big one. All of those have a genetic link there. Ovarian cancer. Same thing, even high cholesterol has a very genetic link there. There's patients that have high cholesterol that you wouldn't even think would have high cholesterol. Like they may look like they're in good shape or exercise. Sometimes, unfortunately, it's purely that genetic tendency there to have high cholesterol or high blood pressure. It definitely happens, essentially. Another big one is mental health. Mental health is another big area that does run in families. So depression, previous histories of suicide in the family, alcoholism, drug abuse, any addiction. Those are things that you also think about as well. Typically, we'll look at 2 generations above, but we also, if they have children or siblings, we also look at that too, because obviously if they have a brother or sister that had a heart attack, they're at risk too. And a lot of this too also changes like our screening guidelines. Like if, let's say, a patient had a father that had colon cancer at the age of 60, we will screen for colorectal cancer in that patient at an earlier age because the father had it, if that makes sense. So that's why it's so important to look at the family tree or genogram, essentially. And like I said, we don't draw out a genogram typically in a patient's chart. It's to get you thinking, like, who should I be asking about and what should I be inquiring about? So sometimes too, we'll look at their children. Like if they had a kid, like let's say another good example would be a hematologic disorder. That's actually a good one because sometimes those don't pop up. Like let's say they had a clotting disorder or they had a bleeding disorder. Sometimes it doesn't pop up until someone has Like for a female, they have really heavy periods, and then they'll get, evaluated, and they find out that they have a genetic trait for a bleeding disorder. So that's why it's important to look at kids too, to be honest, because sometimes that stuff never gets picked up on previous generations, essentially. What, like I mentioned, age and their health, and you could put alive and well. A and W is alive and well. You can put that as an abbreviation. Cause of death for the relatives. I kind of already mentioned all this. Health of very close family members. So, if their children are healthy, you put well, alive and healthy. But like I mentioned, these are some of the examples of good areas that run in families, such as heart disease, blood pressure, stroke, diabetes, blood disorders, like I mentioned, a lot of cancers. So you always want to know about that. Sickle cell, so hematologic issues, arthritis, that's very common. Allergies do run in families, especially a lot of times you'll see that with like seasonal allergies as well. Not necessarily medications, but you'll see allergies kind of run in families. Obesity is one, alcoholism, mental illness is a big one, seizure disorders, kidney disease, TB, etc. TB, you look at that as an infectious cause too because of exposure. So you have to really think about that too. Um, and that's why we always, another thing is a little bit off topic, but we always inquire about travel. In our health history, you always inquire about travel or recent travel to a certain area. So basically, that family tree or your genogram is to basically look at that information of health patterns essentially between generations to look for risk essentially. I'm going to separate this out into two separate little lectures because otherwise the file gets too large to upload on Moodle. So once you finish with this, just go ahead and close it and then go to the part two.